I suppose I'll introduce myself. I'm Fraser Henderson. I'm now in private practice in Maryland. Formerly I was a professor at Georgetown University. I was at Naval Hospital before that, and then with the United States Navy and Marine Corps before that. And had the great pleasure of training with Sunil Patel right here in Charleston. And I think it was a tremendous time where we were mentored by Fanor Perot, one of the great men in neurosurgery. So, click. Say again?
F5.
Oh. Great. Thanks. Thanks, Mom. Good to have a really smart friend. So I'm going to talk about the neurosurgical management of hereditary hypermobility connective disorders. And I have to disclose I'm inventor of a finite element analysis package that computes stress in the central nervous system and of a craniospinal fusion stabilization device. My goals today are to demonstrate that EDS is associated with a number of neurosurgical issues, and that lax ligaments can result in abnormal biomechanics, as Dr. Graham said, with abnormal bending and stretching of the nervous system. Then I'm going to discuss briefly outcomes of 2 studies of craniospinal fusion for craniocervical instability. Now, when someone comes to me with EDS and a history of headache, I think about all of these things to begin with. Chiari, C1, C2 instability, temporomandibular joint syndrome, occipital neuralgia, various aspects of hypercoagulability, Hughes syndrome, pseudotumor cerebri that Dr. Singman talked about, orthostatic intolerance that Dr. Rowe talked about, limbic encephalopathy, neurobichette's and other neuroinflammatory disorders, tethered cord syndrome, mast cell release disorder, neck muscle spasms, thoracic imbalance to begin with. But I'm going to focus primarily on craniovertebral instability. Now, a few words about a few other things we see. The C1-2 instability. We're recognizing this more and more in the EDS population now, and I think this may underlie the neuralgia that Dr. Singman was talking about. Instability between C1 and C2 can cause compression on the C2 nerve root and result in the neuralgia. But this young lady had a significant rotation of C1 and C2 with less than, there's about 10% overlap of the facet joints. You can see here the facet almost dislocating, and this is on turning the head toward the right side. And the treatment is simply a C1-2 fusion stabilization, utilizing these screws in the bodies of C1 and C2, and then a piece of allograft between those 2 bones. We're also recognizing now a number of segmental instability syndromes, especially at C4-5. Now, in the EDS population, we're seeing a number of very unusual symptoms. Normally with a C4-5 instability, you might see weakness, sensory loss in the arms, maybe legs. But in the EDS populations, we often see what we'd think to be intracranial symptoms like word-finding problems, breathing issues, headache, nausea, gait problems, even urinary urgency. So in the EDS population, you have to look for unusual symptoms. So here's a picture of hyperangulation. The MRI doesn't actually look that abnormal. But if you look at Benzil's review in 2007, he talks about the physiological tethering of the spinal cord over kyphosis. And White and Punjabi stated that 11.5 degrees was the pathological threshold of angulation between any 2 vertebrae in a single view. So if you see that angulation, look for myelopathy. And this is one of the reasons why they're symptomatic. With that stretching, you'll see stretching of the spinal cord. In this case, the stretch is more than 20%, and that's pathological. So this young lady on the left had a very normal-looking MRI, some degenerative disc disease. But then on extension on the right, this is an upright dynamic MRI, you see retrolisthesis of C3 on 4, C4 on 5, and cord compression. She was suffering 9 out of 10 pain, was hospitalized for a number of weeks before we finally worked out what the problem was. It took a simple discectomy, fusion plating, and she was out the door in 2 days with no pain medicine. These concepts were discussed in a paper we presented to the Journal of Neurosurgery in 2005. Ed Benzel was co-author. Now, I also look for pseudotumor cerebri. I'm not going to talk about that. Tethered cord is very common in the EDS population. Here you see the conus medullaris descended to the L1 level, which is quite normal. So many people would say this was a normal MRI, except that there's this large fatty phylum, which is one of the soft findings for tethered cord syndrome. The others being spina bifida occulta, a terminal syrinx in the conus, scoliosis, and scoliosis. And those patients make a dramatic and substantial improvement if you untether the cord. Vertebral artery kinking is not so uncommon. We've had a number of patients with carotid dissection. This young lady on the right picture had 2 carotid dissections and a vertebral artery dissection, and surprisingly, she's neurologically intact. Had diagnosed many patients with sinus thrombosis. This left transverse sinus is thrombosed because of hypercoagulopathy. Adnan Qureshi in Minnesota is now doing a lot of important work on this and placing stents to improve sinus blood flow and treating pseudotumor cerebri in that manner. Mast cell activation syndrome has recently been described, and we're finding this in a large number of our EDS patients. It alone causes headache, poor memory, concentration issues. They also have urticaria, dysphagia, asthma, nasalocular congestion, and so on. We see dystonia in about 40% of EDS patients, at least my patients. Also pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. And I've made 2 diagnoses of paraneoplastic limbic encephalopathy. These are autoimmune conditions. I've diagnosed 2 neuro-Behçet syndromes. But we see mostly a lot of Chiari 1 malformation and also even more patients with low-lying cerebellar tonsils that don't quite meet the definition of Chiari. But Chiari exists in 1% of the population by recent studies, and it's defined by descent of the cerebellum through the foramen magnum of more than 3 to 7 millimeters, and I choose 5 millimeters as the cutoff. Now, the treatment for this is variable, but for the most part, it represents, it's simply a decompression of the cerebellar tonsils, the floccular nodular lobes of the cerebellum. Now, this is all well and good, except that about 30% of patients fail the surgery 6 to 12 months later. And that's in part because of the presence of comorbid conditions like Ehlers-Danlos syndrome, which occur in at least 12.7% of Chiari patients. And most patients with EDS have some degree of craniocervical hypermobility or instability. Now, this notion of instability and ligamentous laxity has been in the literature for many years. Menezes talked about it in 1995, how congenital craniocervical anomalies contribute to ligamentous laxity and result in the formation of this granulation tissue that progressively compresses the spinal cord. And Goel and another different population of connective tissue disorders, in this case rheumatoid arthritis, discusses how basilar invagination results from ligamentous laxity. This condition is common in the King Charles Spaniel. Most of these dogs have Chiari malformation and also medullary kinking. And Dominic Marino in New York performs decompressions and posterior fusion stabilizations with excellent results. Now, Goel talks about basilar invagination which is the pressure of the spine against the ventral spinal cord and brainstem, arising in response to ligamentous instability. And this instability causes microtrauma, which causes a kind of a resonating process of increased microtrauma, causes decreased musculoskeletal control of the craniocervical junction, and progressive basal invagination. And he cites contributions of malnutrition, vitamin deficiencies, and other degenerative changes. Now, in the EDS population, we have very commonly more than 60% vitamin deficiencies, some degree of malnutrition, and certainly degenerative changes in all the discs and spinal ligaments. And even 10 years ago, Professor Graham and his colleagues noted that clumsiness, poor coordination, dyspraxia, dyslexia were occurring in an increased prevalence in the EDS population, and suggested some central nerve phenomenon going on, which begs the question, does ligamentous laxity of EDS result in neurological injury? I'm going to talk a little bit about the neurobiology of injury. And I'm going to try to convince you that ligamentous laxity does result in deformation of the nervous system, and this is simply stretching and bending of the neurons. So my interest in this began in 1993 in London. I was asked to look at the cadaveric specimens of 10 patients who had died as a result of this upper part of the dens pushing on the brainstem. These patients died sudden deaths. I was told I'd find vascular changes, to write it up, and would go on to the next paper. Instead, what we found were these silver staining blobs. We weren't sure what they were, but eventually, after reading all of the world's literature, we opined that these were the result of a stretch mechanism. And we published this work in 1993. I don't think many people believed it. But a few years later, Publishok published his seminal work on diffuse axonal injury and showed that stretching neurons results in clumping of the neurofilaments, which are the architectural components of the nerves, and of the microtubules, which are the metabolic highways of the axons. So that these nerves would become dysfunctional, they'd develop an axontomesis, and eventually a neurontomesis. Satman showed if you stretch a mouse optic nerve just 20% of its length, in 3 days you'll see these same axon retraction balls, and a week later you'll see apoptosis. And Wolf showed that if you stretch a nerve, there's opening of the sodium channels, which causes loss of the electrochemical gradient, depolarization of the calcium-gated channels, loss of the sodium-calcium gradient, and a massive influx of calcium into the nerve with its deleterious effects. And I want to remind you that Dr. Ballinger here 30 years ago was the one who discovered the importance of the pathological influx into neurons in trauma here at MUSC. Arendine showed that if you stretch a nerve, you alter the genetic output. And stretching causes upregulation of N-methyl D-aspartate receptors, which are important in learning, in seizures, and also they've been found in schizophrenia in increased numbers. This causes increased vulnerability to nitrous oxide and free radical species. Stretching causes mitochondrial dysfunction, DNA fragmentation, and apoptosis. So, mechanical forces modulate gene expression. They alter biochemical composition. They directly affect neurons, making them more sensitive, more vulnerable to injury. And so we think that this injury underlies many of the neurologic deficits that we see in lax ligament floppy head syndromes like EDS. And again, all these concepts were bundled in 2005 and published in the Journal of Neurosurgery. So what are the tools we use to predict deformative stress? Well, last year, the CSF Chiari Foundation sponsored a multidisciplinary colloquium. We had representatives from China, Japan, Canada, USA, and Great Britain. And we concluded in a consensus statement that was somewhat historical that ventral brainstem compression, medullary kinking, and deformation of the odontoid process are potentially deleterious to the upper spinal cord and brainstem. The deformation of the brainstem may manifest clinically as the cervical medullary syndrome, which is characterized by headache, suboccipital or neck pain, bulbar symptoms including altered vision, diplopia, nystagmus, decreased hearing, dizziness, imbalanced vertigo, choking dysarthria, dysphagia, dysautonomia, postural orthostatic tachycardia syndrome, syncope or presyncope, disordered sleep architecture and sleep apnea, and symptoms of myelopathy, weakness, clumsiness, spasticity, altered sensation, paresthesias, dysesthesia, change in gait, urinary urgency, and frequency. And we also agreed that in assessing the potential for basal invagination or craniocervical instability, that we'd use these three radiological metrics that are published in the literature. First is the clivoaxial angle that Dr. Kobe discussed, a normal being more than 150 degrees, abnormal being less than 135. This case on the right, the clivoaxial angle was 120 degrees, and there's a bending of the brainstem. That's pathological. And the Grab-Oakes measurement, published in 1999 by Grab-Mapstone-Oakes, and on the left is a measurement of 6 millimeters normal, on the right 9.5 millimeters abnormal. More than 9 millimeters or more represents an increased risk for ventral brainstem compression. Bolo and Brockmeyer also talked about it in 2012. And the Harris measurement, as Dr. Kobe mentioned, defined in Toronto for trauma, 12 millimeters or more is pathological. But if we use this measurement in flexion extension MRIs, we can see a sliding back and forth of the skull sometimes, and this is pathological. Here we see 5 millimeters of slide. That is pathological. There's ample literature showing that there should be no more than 1, max 2 millimeters of movement of the odontoid with respect, of the basion with respect to the odontoid. So how do we treat instability? Obviously, the medical management first. We treat the postural orthostatic tachycardia, the pain, hypotension, gastroparesis, correct the vitamin deficiencies. Many of these patients have adrenal insufficiency. We brace them, give them recommend activity limitation, physical therapy, rule out the other conditions. And the indications for craniocervical fusion are severe headache or neck pain. If that headache is mild, then I tend not to operate on patients. Brainstem symptoms, the cervical medullary syndrome that I just discussed, neurologic deficits referable to the craniocervical junction, and radiological evidence of Chiari or ventral brainstem compression or basal invagination and or craniocervical instability. And I also like to see failed response to medical therapy and an appropriate response to bracing. The neck brace provides mechanical stabilization of the neck and should give partial relief. The operative procedure is pretty standard. Head in a Mayfield, prone. We use intraoperative CT, SEPs, and brainstem auditory evoked responses. I do the suboccipital decompression first on the upper left, then place the screws. We try to avoid the spinal cord, the vertebral artery, and the C2 nerve, and have been successful in doing that. And then the reduction is very important. 10 years ago, I performed many transoral odontodectomies. In the last 10 years, however, I've performed hardly, maybe 1 or 2, because most of the time we're able to eliminate the basal invagination with traction and reduction. And this involves pulling on the head and then extending it backwards and then performing a posterior translation. In this manner, we're able, in most cases, to achieve a normal relationship between the skull base, the basion, and the odontoid, the spine. We look at all of these various measurements. I crawl under the table, look at the face, we get another x-ray, finally we get a CT scan. When it's perfect, then that's where we stabilize with hardware and immortalize with a bone fusion. So does decompression and stabilization decrease deformative stress? Well, to look at this, well, here's one clinical article we published in 1994, and of 10 patients with sleep apnea, 6 of them had this basal invagination with compression of the brainstem and drops in their PO2 down to 40 millimeters of O2 at night. And after performing the decompression transorally, we saw a resolution to sleep apnea in every patient. In 2010, we published on 7 young patients. These were mostly adolescents, young adults, who had kyphotic clavoaxial angles, small Chiaris, and were totally disabled. And our goal was to look at the deformative stress arising as a result of the kyphotic clavoaxial angle. To do this, we developed a finite element analysis program called SCOTIA, and this dynamically models the neuraxis within the spine and mathematically predicts the stress resulting from stretch and deformity in what's called the von Mises stress. And it gives us this, these axial views that map out the degree of stress. Actually, we've become a lot more, have much nicer pictures now, but back then, this stress here represented more than 40 newtons per square centimeter of stress, which is very, very high. And this area in the gray matter was more than 60 newtons of stress, for instance. So here's a young patient, 12 years old. He was in the emergency room every week with a cardiorespiratory arrest. And by the time they got to the emergency room, he'd be recovering already. And he had this ventral brainstem compression that's quite apparent by now to you all, and the Chiari. And we simply performed a small suboccipital decompression, but then a traction reduction, and to get this appearance here. And that was some years ago. He became a straight-A student. He's at Columbia studying aeronautical science, and he has a pilot's license flying all over the place. This was his stress image, an axial view through the brainstem, and these stresses here are extremely high, in excess of 60 newtons per square centimeter, and after surgery the stresses would drop down to less than 10 newtons per square centimeter. Now when we looked at all of these patients cumulatively, we saw a drop in the stress of the corticospinal tract, dorsal columns, and the nucleus solitarius. And these drops in stress correlated with the improvement in pain, improvement in brainstem symptoms. This is pre-op, this is post-op, and improvement in the Asia Sensory Motor Index, and the Konofsky Performance Scale, and the physical and mental components of the SF-36 Quality of Life Index. And despite the small n of 7 patients, we saw statistical significance with all of those. So what symptoms improve with stabilization of the craniovertebral junction? And does this improvement support the notion that the cervical medullary syndrome arises from instability? To look at this, we looked at 20 consecutive patients several years ago undergoing craniospinal fusion. And now when I go to the doctor and they give me those long lists of symptoms, I put no on everything. Maybe I'm a liar because I'm from Australia, but these patients put down about an average of 20 symptoms. Some patients had 30 symptoms. So these are very sick patients. Now, what symptoms improved? Vertigo, 92%, headaches, balance, arm numbness, dizziness, speech, neck pain, memory, weakness, walking, gait. They were the most common. The symptoms on the right, for the most part, are probably more due to Ehlers-Danlos syndrome. And the problem with this population of patients is there's not one thing going on. There are many different processes going on at the same time. You have to treat one at a time and then discern the next problem and try to eliminate all of their issues. So we asked them, looking back, would you still choose to undergo this surgery, the craniovertebral fusion surgery again? And all of them agreed with varying degrees of enthusiasm. When asked whether the surgery improved my symptoms and decreased my limitations, 2 patients said that it did not, and I suppose that it's a quandary, but I presume that they had other EDS symptoms. So here's, we did statistical analysis for all of the symptoms, but it's important to recognize that here the headaches went from an average of 8.2 to 4.5, statistically significant, but they're still there. The headaches are not gone, but they're much more manageable. So blue is before surgery, and yellow is after. The headaches are still there, but they're manageable. We have to remember that there are many other causes of the headaches, and that these other causes might need to be treated. In fact, in the EDS population, it's a virtual certainty that they'll need treatment at one of those other levels, one of those other problems. Now, the Konofsky performance status, 100% is normal. 70%, you're fully independent, but you're not quite good enough to go back to work. 10%, you're moribund. So we went from an average of 54 to 74, and from before to after surgery. And looking at the clavoaxial angles, we saw an increase of 20 degrees of the clavoaxial angle, meaning we brought everyone into the normal range. So our preliminary conclusions then are that deformative stress appears to underlie some of the neurological deficits arising in the setting of pathological craniocervical hypermobility and brainstem compression. And the presence of the cervical medullary syndrome should alert the healthcare provider to the presence of craniovertebral pathology and prompt physiotherapy, activity limitation, medication, thorough radiological evaluation, preferably with an upright flexion extension MRI. Surgery should be considered not as should be considered as a last resort. We want to do all of the non-surgical things first, but with careful selection, patients with severe with craniocervical instability appear to benefit from reduction of deformity, stabilization, and fusion. And finally, let me remind you again that there are many, many comorbid conditions with Chiari and EDS, and you have to look for them, and these patients need continued follow-up. I'd like to thank all of my co-workers, Claire Francomano, Miles Kobe, Peter Rowe, Rodney Graham, Alan Pasinke, Edward Benzel, Robert Gerwin, Alex Vaccaro, Stephen Mott, Joel Berry, Mark Alexander, Jonah Murdoch, Jessica Edcock, William Wilson, Rebecca Tuckman. Thank you for your attention. Yes.
Is there a high incidence of spontaneous CSF leak in these patients?
Okay. Question is there a high incidence of spontaneous CSF leak? I suppose I have about 700 surgical EDS patients now, and I have yet to make a diagnosis. Maybe I have 1 or 2 patients with CSF leak, and I've wondered about this. I'm probably missing a number of them, but I also think that in the same way that patients develop neurally mediated hypotension, I think that when they stand up, the CSF flows through the foramen magnum into the spinal, into the thecal sac, which is always enlarged in EDS, and that there's a large reservoir there, and that a number of these patients may get a spinal headache from that drop in spinal fluid pressure. And I've done intracranial pressure monitoring, and I often see negative pressures, which means that CSF is going somewhere. Yes?
When you operate on a person who's still growing, let's say a pre-adolescent or adolescent, are there any things you have to do to make sure, recognize that they're going to have changes in the skull and the neck? Are there any changes in surgery approach you take? Short answer is no.
surprisingly, I've not seen any long-term consequences in doing fusion in young people. They fuse very well. They establish a relatively normal range of motion, and I've not seen any of those dire consequences that are sometimes spoken of. And this is published in the literature too. It's not just me saying. There is some remodeling that occurs lower down in the spine. Bony and ligamentous changes so that the physiology of the spine changes a little bit. But with good physical therapy and alteration of activities, like they shouldn't play football and whatnot, the young people do very well. Yes?
Have you ever used BMP in these patients?
No, I haven't. I don't think I ever will. I think it's reasonable to use it. I just think it's too expensive. There are some complications associated with BMP, but that's bone morphogenetic proteins. It can stimulate bone growth that can ultimately cause pressure on nerves and spinal cord or arteries. Yeah, this is like if you're buying something at an auction and you accidentally raise your hand, so when you scratch your face, now you have to ask a question. Okay, any other question? Oh, yes.
I know you didn't really deal with this in your talk. Tethered cord syndrome, have you any ideas of why EDS patients get tethered cord syndrome?
Yeah, I wondered about this for a long time. I think there are several reasons. First, every phylum I've looked at has been much thicker. The normal phylum is 0.6 millimeters. Every one that I've ever seen in EDS is at least 1 millimeter. So the volume is, like 3 or 4 times greater to begin with. And many of them are 1.5 or even up to 4 millimeters in thickness. Secondly, there's more collagen, which is less stretchy. And thirdly, they have a lot more range of motion. For instance, in the thoracic spine, there should be no significant flexion extension. That occurs in the lumbar spine. But in EDS, we often see increased kyphosis. We see a bowstring effect where the spinal cord is pulled over the thoracic kyphosis in what Benz will call that physiological tethering. And so it's a consequence, I think, of more stretching. The spinal cord is subjected to more stretching, 1. 2, the phylum is thicker and has less give, and it's like a small fishing line bringing in a big shark. That tension is now known to cause changes in the spinal cord. We see a lot of long tract findings and low back pain, bladder difficulties, and this is terribly disabling to those patients. It's the most gratifying operation for me to fix that, and a very low morbidity surgery.
In the normal state, is it normal for the phylum to be tethered? Or is it
no, the normal phylum is the remnant of the spinal cord which atrophies, and it runs from the tip of the spinal cord, the conus, down to the S2 level. And so the normal phylum is tethered, but it's very loose. It's like spaghetti. But in EDS, there's usually tension to it.
And it remains tethered?
Through life. All of us have, the phylum is attached to both ends, but most of us, it's loose.
Yeah.
Yeah. Okay. Yes.
How do you feel about if you perform a tethered cord release and the patient also has Chiari? Do you feel that can then improve the Chiari complication?
No, that notion was actually introduced by Wilder Penfield back in the 50s, I think. I don't believe it. I think it certainly can improve the Chiari-like symptoms, because tethered cord syndrome can cause delayed speech in children, certainly headaches, changes in vision, And numbness in the hands, very common. And of course, you know, the usual findings of spasticity and weakness of the legs and sensory loss, so on. But so I think that releasing the tethered cord, in my mind, does not change the elevation of the cerebellum, but it does alter the Chiari-like symptoms. Yes.
I have just something to share. My 5-year-old just had tethered cord release on Halloween, and she had normal urodynamics and a completely normal MRI. She also has Chiari and was decompressed in 2012. However, when her neurosurgeon cut the phylum, it sprung up into space. So all of those symptoms we're hoping that she's got are going to link back to that. But that's a perfect example of how the imaging and the urodynamics both showed completely normal, but amazing results in the OR.
Right.
Even when it cut.
It's an important caveat. In children, the urodynamics are often normal. You ought to do them, but they are kind of painful. But I hold that tethered cord syndrome is a clinical syndrome, and you employ radiology, as Dr. As a radiologist was saying, that you can look for subtle findings, but the diagnosis is not made by looking at the MRI, it's by looking at the patient. And if there's one thing that Dr. Singman and Dr. Graham and Dr. Rowe have been saying, you have to listen to the patient, exercise a little humility, and usually in one way or another they'll tell you what the diagnosis is. Yes?
The adrenal insufficiency that you mentioned, why is that a common finding in these patients?
Dr. Graham or Dr. Rowe, do you have any ideas why so many of these patients have low cortisol levels? We see it very, very frequently. I think that's in part why they have such high adrenaline levels. You got low cortisol, then you tend to run high on your adrenaline. May be why they're so hyperactive, productive. They're running on adrenaline. I think a lot of neurosurgeons, do you think we're kind of like that?
Maybe.
Yeah. I have to check my cortisol level. Okay. Any other questions? All right, thank you for your attention. Yeah.
Well, that concludes our lectures for the morning, and we are an on-time machine. I love it. It's 5 till 12, so first and foremost, does anybody have any more questions for the panel of experts? Because they are all flying out of here. It's your last chance. Well, hopefully not the last chance. We'll get them down to Charleston in warmer weather. Yes?
How important is it to be diagnosed if you do have Ehlers-Danlos and you have other issues? How important is it to be diagnosed with that, and what difference does it make in the treatment of your condition?
I can't answer that, but did
I'll
y'all...
take a shot at that, if I may.
Go for it.
You don't treat an Ehlers-Danlos patient the way you treat another regular person. Just as a perfect example, physical therapy, you do the regular kind of physical therapy on an Ehlers-Danlos patient, you will hurt them. I mean, you will literally hurt them. It is not standard care for them. They have to be treated, with the physical therapy, for example, much more gentle, much slower, or you could do serious damage. We had an Ehlers-Danlos patient who saw a physical therapist who was helping to release the neck, as they called it, and she came in with a carotid dissection from the release of the neck, and she went blind from it because it was vertebral. So you don't, just an example, you want to know if someone's fragile. In addition, you also saw some issues that Ehlers-Danlos patients have, and we don't know why this is as well, but they have sticky blood. More commonly, they have hypercoagulable states. So you got to be very careful with them too. So for example, if you have an Ehlers-Danlos patient who has Chiari and symptom cerebri, and you give them Diamox, and they happen to have sticky blood, you can throw them into a venous sinus thrombosis, and now you have a whole other problem. So So it is an important thing, at least from my perspective, it's been a very important thing to know. And also for long-term management and how to counsel a patient, not just genetically for their own children, et cetera, and their families, but how to counsel them in terms of what they can do. We had a football player who was a really good player, and it turned out he had it. He came to me with a concussion. We found out afterwards he had it. He had to stop. And that meant a huge thing for somebody who was on scholarship, right? I mean, his school made him stop. He wasn't going to. But you see, it's a very different clinical and social, and even legal picture.
Yes?
Can I just spin off of what he said? I am a physical therapist. I do have Ehlers-Danlos type 3, and I've had to figure that out as a physical therapist. I'm a polyathlete, and you have to treat your patient very, very fragile. You know, it's a fragile person, and you need to really work on core stability and stabilization in every possible way, from the neck, you know, from the C1C2 problem all the way down to low back, every joint, all the way down to the ankle. But it's a very fragile, fine-line thing that I've had to figure out on my own, because I've had to figure all of this out, you know, all the way along, and then also be in that profession. So yeah, it's just something that I am finding patients with hypermobility, and I'm treating them as that without a proper diagnosis, because they're not coming to me with that diagnosis, but they're repeat, you know, they keep coming in with these joint problems, and neck pain, and back pain, and have to figure it out and treat that.
I'm a family physician, and I take care of a lot of EDS patients, and I think also it's important for them to have an official diagnosis to lend them credibility if I'm sending them to a specialist or pain management. It makes a huge difference in how they're treated and whether they're listened to or not.
I think it's very important to make the diagnosis, because the patient needs a diagnosis. They yearn for a diagnosis. Many of them have been suffering in various ways for decades without a diagnosis, and they've been given a sort of push by so many doctors because they think they don't think there's a real problem. I think the average, there was a survey that was conducted amongst our patient, one of our patient groups, the Hypermobility Syndrome Association, which over several hundred patients, which showed that the 50% of them took more than 10 years to get a diagnosis. There's a great feeling of relief when you're given a diagnosis, and there's an outpouring of tears, which I usually participate in, because something that they yearned on, there's somebody to tell them actually what's explaining all their problems for all these years. Sometimes it doesn't happen until they're near the end of their life, and this is really tragic. So I think it's very important to do so. But apart from that, the next phase, of course, is how to treat and address the problems. And as has been suggested, there are many different problems, and they all need to be addressed sequentially, if not at the same time.
I know that I'm a pediatrician in Columbia and EDS, but I see several EDS patients mirroring the fact that not many specialists know about it. So I have patients that come to me that are now going into the holistic and delving into the holistic approach of chiropractic and acupuncture and massage therapy. And I know that just somebody speak to that.
As long as they don't hurt them.
Yeah.
But the fact of the matter is, well, I mean, as I said, as long as they don't hurt them, but I mean, you've seen, I have friends who are chiropractors who do rapid manipulations, and I think that is probably not a good idea. Whether or not any of these, as long as there's no harm to the other therapies, they may offer a great deal of good to many patients. But the reason the patients are turning to those therapies is because they've been sent away from allopathic medicine. And that is not a good reason to turn to those therapies. If you want to make them complementary, they have to complement something. And these patients, they're making them only, not complementary. And that's, I think that's a mistake.
I think it is a little after 12, but I'd like to thank Dorothy Poppy, who is the executive director of the Chiari Foundation, who's underwritten and organized this conference and invited us to come here today. I'd like to thank her and what her organization has done for developing our knowledge and understanding of Chiari and EDS and all these related disorders. So, Dorothy Poppy.
I'd like to first of all thank Stephanie, because there are always like unsung heroes in the room, and she's been fantastic with helping us with the logistics and getting everything done here. Dr. Patel, thank you for giving us the opportunity to do this, and MUSC. I actually got to spend a few days down here, went to a golf tournament on Tuesday for your children's hospital, so it's kind of exciting to me to see all the developments that are going on here. And Chiari and Syringomyelia Foundation would like to establish a chapter in this region. So I'm reaching out to the medical people in the room. We are an inclusive group, not an exclusive group. We're working on projects like an international registry, so we're currently working with the NIH to develop common data elements so that when research is done, everybody's talking apples to apples. If anyone would like to get involved in that, we'd love to have you. We have a great committee from around the country and actually internationally, so that's a great project. We do host meetings the Saturday before the CNS and the Saturday before the AANS. If you can find it in your schedules to join us or participate, we'd love to have you. And then anyone, lay people or medical professionals down here, if you'd like to get involved and start a chapter, we would love to do it, but we need a team down here to do that. So please either contact me, you can find my number on the web, Dorothy Poppy. Go to our website, csfinfo.org. There are lots of videos up there from lectures and symposia like today. So I encourage you to do that to become educated. And if you'd like to take a bigger role with us, we'd love to have you. So thank you again to everyone here.
I believe Stephanie has already volunteered to help you out. Well, I want to thank everybody and the speakers especially. I hope you have a safe trip away from here, and hope to see you back in Charleston in the warmer climate. Thank you.